going to talk a bit about estimating costs, and I am an economist, I am an academic, so I'm going to lecture a little bit about what we expect on unit costs. So I'm also the lead economist on the STAR project, so we've been out there collecting a large number of observed costs, both in facilities as well as in the HIV self-testing. So we're collecting those to inform both the cost effectiveness, but also to inform the cost of scaling up. In the literature, but how best can we do that, I'd like to talk about. In the literature, there are 4 methods that are commonly used, 3 methods that are commonly used, and I'm going to propose one variation to it. Someone has touched my slides and they're not the right size anymore. I'm sorry about that. That is a shame. Okay, so this is unit costs. We use average costs, are commonly used, are the most common input into cost effectiveness models, mathematical models, and so Valentina, these are the kind of costs that you use when you're doing your mathematical modeling. The assumption underlying that is that costs are constant, and so when you scale up to get your total costs, you just multiply that cost by the quantity. And maybe with a mature program it's suitable, but it does ignore the fact that of economies and diseconomies of scale. If you all go back to your textbook economics, many years ago for some of you, which come about where costs initially will decrease and then they'll increase over time due to fixed and variable costs, so the fixed costs being spread over more output, but also program learning can reduce costs. There are changes in input prices that happen as you scale up. You might be having different service delivery models, which you may be able to account for in your impact, but if we don't have costs for them, we may not be able to account for that. And also something very close to my heart, because not only do we do cost effectiveness, we do a lot around demand, is demand constraints. So as we are initially introducing HIV self-testing, we might expect high levels of demand, but as you mentioned it, Bernie, those hard to reach populations towards the end, those very resistant people, we would expect higher costs over those. So a unit cost approach will not allow for that to be taken into account. The next approach, which economists love, but is very data intensive, is to estimate cost functions. So we estimate total costs or unit costs as a function of all the different things affecting them. Program maturity, type of model, the quantity of output. And so we all love doing this, us economists, but in a program like STAR, we'll never have enough data to actually estimate cost functions very well. We might for our facility-based costing, where we have a baseline and a follow-up for routine testing, but with 56 sites distributing HIV self-tests, we won't be able to do that. So a third approach that is proposed by Gesine, Meyer-Rath, and Meadover is accounting identity. This approach is pretty simple. It takes into account that you have fixed costs and variable costs, and at a facility level, you take into account your, for example, your building costs, your training costs, and possibly your salaries might also be fixed depending on how you pay your staff. And that's where, let's see, where's my pointer? Is it? Which one is a pointer? Which one will be the pointer? Oh, not that one. Okay. Let's see. No, I can't get it. So at the beginning where you see a total cost is starting up a bit higher, those are your fixed costs, and your variable costs will lead to your upward sloping total cost curve. This is good, but it doesn't take into account above service level costs. And obviously something like a program like what we're doing has a lot of above service level costs. So we want to have a bit more nuance. So we recognize that most costs are chunky, so they're fixed at different levels. So at an individual kit level costs, you need to multiply by the number of kits distributed, but each distributor will need another t-shirt, so that's a fixed cost by level of distributor. Each outreach site, you need to get there, so it's fixed by outreach site. And at a clinic level, you have your storage facilities. So already that accounting identity has a number of layers of fixed costs. So that's what we want to expand in a little more detail. So with the incremental cost multiplier approach that I want to propose here is we are going to identify the costs at different levels. So if you're doing a standard unit cost, you would allocate all the central costs across the regions, and then you'll allocate the regional costs to districts, and you'll allocate it all the way down so you have a fully loaded cost per kit distributed. But for multiplying that up, that doesn't quite work, because each level, as you scale up from 3 districts to 20, you'll have different multipliers for each of these level costs. So what we're going to do is we are going to estimate total costs, but identify each level, what are the fixed costs, and how much you need to multiply them by. Have I lost people? Are we all with me? Good. So what we do is we do a top-down costing. So we start with all the accounts, all 9,000 line items of them. We identify whether it was a startup cost, whether it's a cost that's incurred at central level. So central level costs can be both the headquarters, human resources, but also the central teams that are there. And then you'll have your district level costs, distributor costs, and kit costs, and each of these will need to be multiplied by a different number to get to your scale-up costs. And so then you get a cost function, total cost function, that is not smooth anymore, but chunky. So you have your startup costs are high at the beginning, and then as you expand to an additional district, you'll get another increment, and if you expand to another region, you can expect another increment going straight up. It still doesn't take into account diseconomies of scale, and we'll talk a bit more about that in a moment. Okay, so what are the steps to doing this? First, when you're thinking about your own system, you'll have different levels at which expenditures are incurred. So in each of our different countries, Malawi, Zambia, and Zimbabwe, we have a different distribution system. So some will go straight from the distributors to the sites, some will have intermediaries at district level, and so depending on what your system for distribution is, you need to identify at which level costs are being spent. Then you need to estimate an average cost at each of these levels, and then multiply to the scale that you're aiming to get to. So let's have an example. So the example is Miriam presented yesterday, the Zimbabwe model, where you have door-to-door distribution, sequential. So the field officer team goes to site 1, and then they move to site 2, then they move to site 3. After they've spent a month distributing in one site, or after 2 weeks, the New Start clinic will come and be close to these communities where people can go for confirmatory testing. And so site by site, it moves on. And so that's the example I'm going to use. We haven't costed all the 5 districts that they've been to yet. So I'm going to show an example based on the 3 sites that they've been in, but do recognize that they have made more progress since. So we have 3 districts have been costed. They employed 382 distributors, and almost 41,000 kits were distributed. So to think about scale up, what are our intermediate outcomes that we'll need? So each district, they had about 14,000 kits distributed, and now I think actually it's improved with their new site. So I've updated it with the 5-site average that Miriam presented yesterday. So this is a live presentation, that's why I keep changing things. But I didn't have the number of distributors that were employed at those extra sites, so we have about 107 kits were distributed by each distributor. So if our scale-up target for phase 2, the first year of phase 2, is 320,000 kits, we can calculate backwards. We need to reach about 21 sites and employ about 3,000 distributors. This is not yet going to recognize that efficiency is likely to improve, but we are going to update these estimates. It's a live model, so we'll continue to estimate how numbers are changing. So as I mentioned, we start with our project accounts. So 9,000 line items, as I mentioned, for Zimbabwe. We have over 4,000 line items in Malawi and many in Zambia. So this is how we start. We like this approach because it's very transparent, and so when we go back and forth between the accountants, they can track exactly what we've done. And so it's really critical when you're costing to have a very transparent approach. Everyone makes mistakes, but also there will be line items that you, as an economist, you don't quite know what they mean. So you need to be able to go back and itemize everything. We're doing a costing by input type. We're doing a costing by model, so a distribution model. And now we've added the column of level, so at what level the cost is incurred. So that's our first step, and budgeting and scale-up costs are at the financial cost level, but we are also going to do an economic costing, which takes into account the full cost, so includes donated goods and services. And then when you add user costs, you can actually get your societal costs. And this is really critical in a technology like HIV self-testing, where actually you're transferring costs from users to providers by bringing it closer to home. And if you only look at the provider costs, you may think it's more expensive, but actually you may be alleviating costs from users. So when you put together the societal costs, it'll give you a lot of insight into the true cost of the intervention. And it may not be as expensive as you expect. That was a little side plug for societal costs, nothing to do with budgets, but I had to tell you. Okay. So what we did, our actual practical example, we identified the startup costs. So those are all the costs incurred before the first training. Program development, development of materials. You only have to do that once in the life of a program. So we only need a 1 in our multiplier, and we don't need to repeat it as we expand. Central costs, we may need to expand a bit as your program expands, but you won't need to expand it linearly for each district that you expand to, or linearly for each kit. So that's why we're separating out all these costs. We have the field officer team and their equipment, because again, as Bernie mentioned, they have their tablets that they need to go from site to site, but if you have 2 field officer teams that are going in parallel, you need twice that equipment. Site level costs, distributor level costs, and kit level costs. Okay, so I'm going to show you what we've done. Now, don't look at these numbers. They're not precise. I know that you all want those unit cost numbers. These are some approximate numbers that we have started with. They're approximately correct, but they're going to be adjusted, and they're only for 5 months, right? So we have some program costs, which are about, so we have all of our observed costs in our first column at each level. We have the quantity that we've observed. So we've only observed 5 months of a year's costing, and normally we would do costing over a year, and that would spread a lot of the fixed costs across. That's why I don't want to emphasize our total costs or our unit costs. Then we get our average cost observed, right? So for a full year, that would be, you need to multiply. You have your field team costs, your district costs, your cost per distributor, so that's their salary and all the things, their promotional materials, their t-shirts. And then our cost per kit distributed. So in our early part of our intervention, the cost was $3.70 for our first invoice. For our second invoice, it was in between. And the most recent invoice, it was $3.50. So we're using that for our first scale up. But when we scale up nationally, we'll use an even lower cost. So that's really lovely to see how prices are changing, and we can incorporate it. So this is our first projection of our scale-up costs for phase 2, and you see a dramatic reduction in cost per kit distributed. So if you were to use our first unit cost in our projections, that would clearly not be correct at all. And now we did a second projection where we looked at national scale-up. So we have the same first 4 columns up to the observed costs, except for the price of $3.15, which is expected for 2018 and 2019, and hoping to get it lower. But as an economist, I like to use observed costs, so I'm not going to use the $2.50 projection now. So we estimate that if we are going to scale up nationally to about 1 million tests, assuming no efficiency gains, we would be able to reach a unit cost of about $9.23. And you see a large shift from the contribution of higher level costs to actually the cost per kit distributed. And that's quite common as you see programs mature. The actual product will take up a larger share of the costs. So one thing that's critical is to keep updating. So as you get new data, you want to be updating it to ensure that you're using the most up-to-date model, up-to-date estimates. So this is an approach that I think is fairly feasible for a lot of programs. It's not too complex of using cost functions, but it is more informative than just using unit costs, and it's more informative than just using health facility level costs. But there are still remaining challenges. We need to really probe further into our observed costs, looking at how costs are changing over time. We know that your unit cost is just at one point of time, at one quantity in one place, but we need to identify what are the drivers of those costs so we can think about transferring them to different settings. And if we don't present what the drivers are of our costs, it's really difficult to say, oh, in Uganda it's going to cost this much, right? You need to really be looking at what the drivers are. We expect changes by early demand, later demand. Trying to get to those resistant testers is going to increase costs. We expect our unit costs to be our test kits to be going down due to bulk procurement. But also as you get staff shortages, your unit costs may go up. You may get more management complexities. But then again, you may be integrating more, so your costs may go down. So you need to take into account and think through the different dimensions that will be affecting your costs and update your costs periodically to be able to take this into account. And ultimately, what we'd like to do is use these costs not only for budgeting, but also for cost effectiveness. So they can inform our cost effectiveness modeling, and by dividing it by level, it's useful to feed into these types of cost effectiveness model and get our cost per DALY averted. So just to conclude, lunch is almost there. I've shown you a few different approaches to modeling scale-up costs. Average cost, very simple, likely on the high side for some things, likely on the low side if they're not fully loaded costs with above service level dimensions. Cost functions need a lot of input, so they're complex but so much fun. So we've proposed an approach in between, using your incremental costs or your fixed costs at different levels and using multipliers to use a programmatically and operationally feasible approach to scaling cost up. But you do need to make sure that you are incorporating above service level costs. If we budget too low, projects just don't happen. I remember presenting costs of syphilis diagnostics at WHO, and someone said, you don't need all those management costs. I said, yeah, you don't, but if you go back to Zambia right now, you won't see any syphilis screening going on. At least that was what we were looking at. And maybe that is due to having cut all those management costs. So you need to take into account that, yes, you can cut some of the management costs, and some of those types will be spread across more units. But if you spread them too thinly, interventions do stop working, and changes in demand over time.